So today we're continuing with the leadership in terms of making the connection and using successful communication. Um, it says during stressful times is the title here we've gotten from the Institute for Healthcare Improvement. But I saw a patient yesterday who actually is somebody that helps staff nursing homes, and she said it's just like all over the place in terms of just the anxiety and the stress because you got people coming and going, staff retention, staff leaving, staff new people on board, and it was pretty clear that was an ongoing thing. And the thing that was really quite revealing was that this staff member had no time off. I mean, she was reporting that she would be called on a daily basis to contact nursing or CNAs to fill absentee positions 7 days a week. And she says this has been going on since December. So for the first time, I wrote a prescription that indicated that this individual needed 2 days off per week, and that the facility needed to keep her facility-issued cell phone. It was just very representative, I think, of how people are accommodating, but then quite honestly get taken advantage of. There needs to be definite boundary lines for leadership and others. I mean, there need to be handoffs, and I don't know, people, we might want to talk about that as to how we give those handoffs to others, for shared responsibilities. And it's the same thing that we're trying to do with the quality improvement, is that there are shared responsibilities. While we have usually identified a leader for QAPI, that it's really important to kind of spread the change amongst all staff members, and that you keep build an empire of quality improvement officers throughout the facility. And those quality improvement folks can include different levels of staffing, including housekeeping and CNAs, for example. So with that said, looks like we're kind of into our 5-minute window here. So let's kick it off here. And Casey, I think you're the controller of the slides today. So this is today's curriculum. So again, the Institute for Healthcare Improvement, IHI curriculum is brought to you as a national collaboration for what we call the ECHO COVID Action Network for nursing homes. And today's continued theme is on communication. And we'll have a discussion a little bit about our project du jour that we selected for falls. I think everybody recognized that the fall rates have kind of gotten out of control so after the pandemic surge here. And then we'll have a little background information on falls etiology and prevention. Okay, so why don't we go to the next slide here. So as we've done traditionally here, we'd just like to get a response for whether you did walk-rounds last week and what was the key point that you learned from your walk-round. So if you can put that in the chat box, that would be wonderful. Just as a reminder, while you're putting into the box what your walk-rounds revealed, we last week, it was the identification of persistent stress that people are reporting. And I hope that at some point, as we recognize staff stress, that we also have some information about patient and family stress too. So just if you have done your walk rounds, what key point that you did find out. Yeah, thanks, Cindy. Staff are concerned about the COVID screening and think we get paid big dollars. Well, sure. I mean, some long-term care, what was a Good Sam Society, they were spending $50,000 per week on screening, and nobody was reimbursing them for that. So I don't think they exactly were making money. Quite the opposite. So the other point is we're getting feedback in our chat. Part of the issues with the walk-arounds is to have them to be structured, right? So remember, we were comparing the really good administrative leadership that would do walk-arounds, get to know everybody, know their names, ask how things are going. But then the really super duper walk-arounds are structured by asking specific questions. Did you see anything with infection control this week that needs to be worked on? And any lapses in things like mask wearing. I find it very interesting. In my clinic, and just to give you an example, in my clinic, the patients who have been vaccinated take their masks off in the clinic, and half of them ask me because I always wear my mask. And they asked me, I said, is it okay if I take my mask off? And so it's sort of like, well, it's kind of too late. You already have your mask off. So, I'm not sure what the permission is. And quite honestly, this whole thing about, people wearing masks and then lifting the mask up and sipping, I mean, I don't know. It's just an interesting observation. Even when I was at the airport over the 4th of July, there are some individuals who attitudinally believe, even though it says big signs, when I was at O'Hare Airport in Chicago, it said, you are required to wear a mask. And so the people, when they're eating, they take their masks off. So I guess that's permitted, right? So you have these characters walking up and down, passengers walking up and down the hallways, just, with their cup of coffee. And so they got that cup of coffee, so that exempts them from wearing the mask. They're not sipping on it; they're just carrying their coffee. So that sort of gets them off the hook, I guess. I don't know, but people have some very interesting interpretations about mask wearing, and it's and again, we have to re-examine what the whole point of the mask wearing. So there's a reset point that's going on currently, right? We're in a lull. With the COVID pandemic, but what is emerging is the Delta variant, and that's what we're trying to protect people. So it's sort of like we're starting all over again in a sense of how are we going to do our best effort to protect people from COVID and the Delta variant. So we've got a real heads up, but we know it's coming, and the anticipation is that in the fall, it'll be in full force. Again, it'll be like influenza, the waves of, influenza that occur each year. Yeah, so thank you, Sarah, for the information there about the staff being upset about continuing education on COVID vaccines. You said that they've been educated and it should be left at that. I had one staff tell me, I feel like it's peer pressure and unfair to the staff. Well, whatever. I mean, I'm not sure there's a pleasant way to do it other than, to insist on staff vaccines, and, some hospital systems have done that, right? They've established vaccines, and, the people that are unaccepting of them get let go.
Dr. J, up on our our IHI coaching call the other day, and so it's interesting you brought it up, Sarah. There is a lot of facilities that are reporting that the staff are not getting the vaccines because they say it's their choice and they still need to control in something. And I feel like that makes sense for the line staff in the facilities. And what some facilities were doing where they had a more positive response is they let off of the education and asking people to get vaccinated. Instead, they said, you do have a choice. You can get vaccinated, or you continue to wear, ABC, PPE whenever you're in the facility. And they had more of a turn on people coming in and getting vaccinated then because it was more of a choice to them opposed to you have to do this. So it's as if they need that control to make that decision, and they know it's in most facilities it's not required, so they have an opportunity to say no. And they saw a better response when they pulled back from the education and constant, are you getting your vaccine? Are you getting your vaccine? Are you getting your vaccine? So
Yeah.
just a thought.
Yeah. So it's always an invitation. I mean, I get ticked off. I have to get my influenza shot every year. Really annoying because I have to get it documented. I mean, I get over it. So I don't know. I'm not sure if I should use myself as an example. That's terrible to do. But I think it just represents that sometimes when you're in the healthcare industry, there are certain expectations that are set for protecting self and others. And I think just as a reminder and a look back, the reason that the pandemic really blasted off was because of healthcare workers. Okay. In China, the unvaccinated, the unprotected healthcare workers were the absolute spreaders. It wasn't the market. It was the patients that came to the hospital, they got sick, the medical staff got sick, and there was a huge death toll that occurred in China. We don't hear about it much, but there were a lot of physicians and nurses who died, because they were not prepared for this, this pandemic. So I guess that just puts it in perspective as what our folks and what everybody's commitment is to healthcare in general. Maybe it's not the right choice, if you can't protect others and your family. The other point is that, and we don't talk about this too much either because we don't know, in anticipation of the Delta virus promulgating, and spreading throughout the country, anticipated during the fall, is that we don't know the vaccine effectiveness in older adults against the Delta variant. So for example, a study just came out in Israel that showed that it's 63% effective, in terms of protecting from, strong infection. So 40% will get a heightened reaction. Still no deaths, which is good news, but you're subjecting frail older adults to, if they get exposed to the Delta virus, and again, people can get reinfected with coronavirus. We don't know exactly who those people are, but there is recurrent infections. So for all these reasons, it really makes sense to get vaccinated. And to get God forbid if they're not getting vaccinated, what happens when the boosters come about. So like I say, it's just like influenza. And I don't know legally what's going to happen, quite honestly. This may be an issue so that if somebody who is unvaccinated, so right now 100% of all deaths in the United States from COVID are due to unvaccinated people or are associated with unvaccinated people. So if you have somebody that transmits the virus, to a resident and they were the vector, I'm not sure, what their liability is going to be going down the road. Everybody was exempted, from the liability, but I'm not sure that's going to hold up now that the vaccines are out. So Michelle has mentioned here, we need continued education as we learn more about the vaccine works and the dangers of the illness with the variants. This is absolutely true. And to promote best practices for your facility. Yeah, and the other thing that's going to be interesting is that once the vaccines become FDA fully approved rather than contingency approved, you're going to have full authority to mandate the vaccine. And again, part of that may be, preparing staff for, getting vaccinated and alternatives if they don't. I know staffing is always an issue, but that may be part of the plan that you're going to have to work on. I also want to mention kind of shout out to Mary O'Meara, who was talking about staff are stressed having to wear masks. Yeah, I share that stress, and I don't know. People are mixing it up. They're having different kinds of celebratory masks. Different colors. You can have teams with different colors. The funniest mask. I don't know. You can actually turn it around and perhaps have a competition. Also, as a reminder, that the efficacy of the N95 masks is equivalent to the mask with the surgical mask with the rubber overlay. So you can convert the surgical masks into a 99% efficacy with those rubber overlays for a little contoured fit. Good. Okay. Well, thank you for the feedback. And again, just as a reminder, I would continue to encourage everybody to have your little 3x5 card or equivalent with questions that you can change each week. So it's a structured, question rather than just walking around and just asking how things are going. Just have some specific questions each week that you can do. And of course, some people do more than weekly rounds. And likewise, having a structured, question-specific walk rounds is very important. And also during that time, if you can, solicit or encourage people to come up with ideas for quality improvement. So the question is there anything that we can do differently and improve in such and such category? And you fill in the blank what that category is. It could be housekeeping, it could be food, transportation, falls, right? We're talking about falls. All right, wonderful. Can we get the next slide, please, there, Casey? Okay, so this is kind of an open-ended question. So in the chat box, again, we're looking for your thoughts. Is how do you ensure that your team hears you when you're communicating with them? And I'll just give you an example. Yesterday in clinic, I saw an older gentleman. He was in his mid-80s, and I said, "These are the 3 things that I want you to do for fall prevention." Right. So I want you to do what we call the yoga stance, the tree stance. I want you to do stand up, sit down, and I want you to do lunges. So those 3 things. And so by the end of the clinic visit, I said, "Now tell me what those 3 things were." And he looks at me and he goes, "Well, I had to do something." And I said, "Yeah, but during your TV commercials, what are you supposed to do?" So I jogged his memory a little bit. He says, "Oh yeah, I'm supposed to stand up and sit down." And I said, "Then what's the next thing you're going to do? You're going to stand next to a table and you're going to hold on to the table and you're going to, oh yeah, I'm going to lift my foot up and balance on one foot." So again, it's, I think we know this, at least in the nursing and, medical fields for sure, that we know this as the teach back methodology. So anyways, I'm just kind of wondering what you do when you communicate something to your staff, either, well, primarily as an observation, like, we're 75% effective in our mask wearing, right? So how do you get feedback from them on that? And it could be written feedback, it could be, verbal on the spot feedback, and so forth. I don't know if Michelle or Kelly, you want to mention anything about getting cues or points of,
I really think communication is a huge part of making sure that your staff retain information that's necessary to care for the residents. And if your staff aren't really hearing you and can't regurgitate that information back to you, then are they really taking it in? So I think that's why we want to talk about this. And this is part of the IHI video this week is really based on communication. And just think about this as you're watching that video too, and see if any of those things are what you're doing in your facility.
Yeah, I like Cindy's response. So Cindy Galls is saying that they have both a written. So a lot of people will use whiteboards and will write things on there. And I personally am very big on imagery. You know, so trying to connect an image, and this actually comes out of the Mayo Clinic medical education office, where they say nowadays, you know, the fewer words you have, the better, and more emphasis on an image, because people have a visual image much stronger. And you know, it's interesting, if you ever read the book about Bob Hope, who is, you know, the famous comedian. He would say that all of his jokes had a visual image to it. The funniest jokes, you know, you could see a guy hitting a golf ball and, you know, falling flat on his bottom. You know, that had a lot more impact for humor than they're just saying that somebody went golfing. So that was an example. So I like the written messages, and then, you know, the huddles, right? So you know, the book that we were talking about, the Farrell book that I hope all of you have gotten so far that have requested it. One of the stories in that book was having what they called community meetings. So in between shifts, they used about 30 minutes in between shift handoff. So they had a 12 and a 12-hour shift. So they had what they called community meetings, and the administrative lead would bring the whiteboard in and, you know, list all the main points. And so some of the points that he made were all the new doctor orders that showed up. And so, you know, let's say there was a lot of Tylenol prescribed, you know, during the last 24 hours. So the question becomes, is that Tylenol for pain, or is it because of temperature, right? So what are the trends that are occurring, and people would discuss it. Okay, thanks, Mary, for saying. I'm just mentioning on the side here about not receiving your book. We'll double check on that. So I think we got the message out, and our administrative assistant went on vacation here last week, so there may be a little bit of a gap there, but we'll get the books out to you. All righty. Well, so I think just, you know, in the point is just to remember, try and get feedback from staff. And also importantly in the communication, and I'm terrible at this, is that you will have, let's say you have 6 staff members, let's say 6 CNAs, and 2 of them are chatting it up, and the other 4 are very quiet. It's very important for you to kind of hold the fort on the other 2 and turn to the other 4 and ask them, what do you think? And get their feedback. So it's always, you know, full participation in all these. So here's a question to think about. You know, what is the biggest or most vital part of communication? And I'm going like, you know, I'm thinking about that myself, and you know, to me, the top thing and the most vital part of communication is being effective. You know, just because you're saying something doesn't mean it's going to sink in. And you know, and quite honestly, it's well known in studies that when you give a presentation, let's say for, you know, 40, 50-minute presentation, your audience will retain 1% of that within 10 minutes of that talk being completed. So again, a lot of these things need to be reinforced over time. So just because you made the point once doesn't mean that it's going to be retained. So retention and then application to practice are the other elements. Yeah, I like this. Mary O'Meara is talking about being engaged on both parties. Absolutely. So full disclosure, that's kind of what we're trying to do here, is, you know, a give and take on feedback, you know, through our chat room, and yeah, trying to be fully engaged. So I like that. Thank you so much for pointing that out.
And this is just food for thought. You'll get some more answers in the video, but just something to think about when you're watching.
Yeah. So it's kind of like a pre-video teaser, right? Which I try to get some ideas about what we're thinking about. And if you see your idea in there, then that helps reinforce that concept. Okay, so maybe we can move on to the. We have the video next, right? Yeah. So let's listen to that.
Welcome to Module 3 of the session on leadership roles and behaviors in supporting teams through the COVID-19 pandemic as it pertains to psychological safety and well-being. And the topic for today is making the connection, how we ensure for successful communication with our team members during stressful times. My name is Sarah Sjostrom. I'm proud to serve as the Associate Chief Nursing Officer at Hebrew Rehabilitation Center, and I'll be walking you through the module today. So we're going to begin with a little bit of biology, and bear with me, but this can be very important in understanding why people respond to stress the way that they do, and then can help us guide our interventions so that we can mediate that stress response as we communicate with team members. So I like to think about the brain on stress as akin to that 1980s Say No to Drugs campaign of, the fried egg. This is your brain and this is your brain on drugs. And it's not unsimilar when it comes to stress. So this is your brain. This is a normal, regulated, calm, alert adult. And as we develop that calm, alert adult brain, our brains from childhood to adulthood develop from the bottom up. So first we establish these very basic systems of survival: sleep, eat, thermoregulate. And as we grow and develop, we build systems and more mature systems for complex emotional behaviors. And finally, last but not least, the neocortex develops systems that allow us to think critically, to analyze, to use rational thought. And you can see in a calm, alert adult that neocortex is functioning at almost full capacity. This is your brain on stress, right? This is the fried egg in the pan. And you can see very clearly in a visual way that what happens when our brains are stressed is that some systems shut down and some systems then pick up that slack. And you can see what is most heavily affected in terms of our system's ability to function is the neocortex. So we shut down the most capacity that we have for rational, clear, critical thinking, and we divert those energies into mere survival mode, right? The fight or flight, flock or freeze. And the dysregulated adult then tends to only focus on that narrow subject of survival and also tends to be more emotional in nature. And this becomes incredibly important when we consider our interventions and how to communicate with someone who is in that state. So as we just discussed, team members that are under significant stress don't have the capacity to think critically and think rationally in the moment if they are incredibly stressed. And that becomes critical when we think about how we're going to communicate with our team members. A stressed team member cannot rationalize. They cannot hear you if you can't first meet them where they are, address the primary concerns, and then move forward with communication. So it is vital for someone who is stressed to first make sure that they feel safe, allow for them to feel more calm, make the connection with them, and then you can begin a more pertinent discussion. And important to think not just about their personal and mental safety in terms of calming them so they can hear you, but also their physical safety and the physical environment in which you're having that conversation. Sometimes simply physically removing someone from a stressful environment can allow them the calm they need to better be equipped to hear you and communicate with you. So there are multiple factors to consider when considering safety and calm and connection first. Another critical factor for leaders to consider is that laying the foundation for connection and for successful communication begins way before times of stress. This is an essential function of a leader to ensure that you're able to build trusting relationships with those on your teams so that when you need, in times of the most stress, you already have an established connection. So start early. Begin to build rapport and trust as soon as you can, and recognize that relationships build in stages and that this has to happen over time. We start as acquaintances, and slowly as relationships build, people can get to a point where they feel comfortable being vulnerable, being open, thinking outside the box together, being creative. And that's essential for good team function, but it takes time. And as leaders too, it's important to recognize that it's a two-way street. And in order for employees and team members to feel safe trusting you, you need to trust them, be giving of yourself. It's a give and take. Another vital part of communication, which becomes even more critical during times of stress, is understanding the old saying, it's not what you say, it's how you say it. And this is very true. We say so much without saying anything at all. And we often tend to overvalue words. We think a lot about what we're going to say and not enough about the tone we're using and what we are doing when we are speaking. Words only account for about 7% of what we are actually saying. Our tone accounts for 38%, and our body language and our gestures are 55% of the message that we're giving. We as humans are incredibly emotional creatures, and we give a lot more value, place a lot more value on those nonverbal cues. So it's really important to consider that gesture and tone play a huge role in communicating our message to our teams. And in times of stress, we are more likely to rely on those. And another key point is that if our tone and body language contradict what our words are saying, as those emotional creatures, we are more likely to believe the body language and tone. So as leaders, we have to constantly be assessing it's not just what we're saying, but how we're saying it. The final component of successful communication that we're going to discuss today is that it is truly important to recognize that there's not a one-size-fits-all approach. As leaders, it's essential that we recognize that our team members are all unique individuals and they may need communication provided in different ways. It's also important during these stressful times to think back to the stress continuum model that was discussed in previous modules and understand that in very stressful times, people may be anywhere within the stress continuum and may need to first have their needs met in terms of feeling more calm, feeling more competent, feeling more connected. They may need something addressed first before they can truly hear you. And also, and finally, be very sensitive to any cultural considerations that may require you to communicate differently or understand the needs of an individual on your team differently. Thank you so much for joining us today, and we look forward to seeing you in the next module.
Thanks for your comment there, Mary. I think you pushed send as soon as she started talking about meeting each employee, meeting their needs in order to communicate and getting to their level, and even more important in times of stress when they're not functioning at their highest capacity. So I'm glad that's something that you recognize whenever you're dealing with your staff and how everyone is unique in their own way, and that's how you have to communicate with those folks. And then the food for thought was your body language and your tone is how critically important it is whenever you're talking to staff, and how they may not even hear your message if the words don't match the body language and the behavior. So as leaders, those are just things that we have to keep in our mind whenever we're having those conversations.
Yeah, thanks, Kelly. I just as again, a disclosure, I find myself having to raise my eyebrows quite frequently when I'm trying to converse reasonably without conveying angst or anger, because over many years, I've been a very serious kind of guy. I always take things so seriously. So I've got these like etched furrows in my eyes that kind of look like I'm, what's the, not Big Bird, but the one of the other Sesame Street characters, Oscar the Grouch. And so I have to be mindful that my old age wrinkles sometimes give a false impression that I'm, not disturbed, but have an angry look on my face. So particularly with Alzheimer's patients, right? Because when they see those, lowered eyebrows, whoa, that's a key to them that something's up, something's wrong. So always using those kind of more expressive, wide open eyes.
Yeah, absolutely. And your tone these days is far more critical, I think, than your facial expressions, because most of the time your face is covered.
Yeah.
So I think that that's something you've got to pay a lot more attention to, because you can be smiling and may not be able to see that.
Yeah, no, that's precisely correct. It's too bad we don't have some digital masks, where we can see the. Of course, they have those plastic masks that Ford Motor Company made, and we've talked about that before. And a couple of folks have tried it and have not been too enthusiastic about the clear masks. But that again, changing up the masks may be another way to deal with mask fatigue. So that's, again, just a thought. Variety is the spice of life, and so that's a thought. Okay, so we want to kind of move into our project improvement. So Kelly and Michelle, do you want to comment about that?
I think we have someone sharing today. Jean, are you?
Yes, we do. So back in May, we heard the team from Ave Maria share their PDSA around loneliness and the impact that it had in their facility. And since that, they've been very busy on other work. And today, Billy Zupan, who happens to be the Quality Assurance and Admission Director at the facility, is going to share their work around their falls reduction program and the impact that root cause analysis and individualized interventions has had on their fall rate. So Billy, I'll let you go ahead and take it.
Hey guys, Billy's working on another admission right now on the other side of me. So I'm Andrea again. So she wrote it all up nice for me. So I'll just go over it here with you guys. All right. So, I mean, it's not like we want to jinx ourselves or anything, but we have seen a decline in the overall number of falls in our facility. We were in the 92nd percentile on the Casper report when we first reported, and we're currently in the 89th percentile, which remains high, but it's still a huge win for us. We've struggled generally just with the population mix of the type of residents who we have here. Fall rates have always been higher for us, unfortunately. Our nurse managers and social workers were very busy and reviewed every single resident's chart to ensure that we had a patient-centered activities list in their care plans and on the routine care sheets for the staff to use to initiate activities for any residents who were restless or anxious. So we went through, like, anytime we had falls, and went through whether there was any interventions that they had and didn't have. So we do continue to have one resident who accounts for the majority of our falls. But we had a meeting all about that particular resident and all of her falls, reviewed the past and current interventions that we had utilized. We stopped the interventions that were not effective and initiated some new ones. But we didn't want to initiate too much at one time, because then it's just like giving more than one antibiotic at one time. You don't know which one was effective or which one gave you the allergic reaction. So far, fingers crossed, it's proven to be effective with the resident. So she was falling at least daily, if not 2 to 3 times a day. And what is she down to now? She's 2 to 3 a week is where we're at now with her. So doing a really focused approach with her. We brought in one of our CNAs from the floor that had worked with her, along with, the multidisciplinary team, and went over what other things we possibly could do for that resident. And so far it's been effective. It's just been a lot of diligence. So our fall PIP committee continues to meet. It's a committee that includes staff from the following departments. We have nurse managers, social workers, nursing, CNAs, housekeeping, and dietary departments. Dietary and housekeeping do see things when the CNAs and nurses are busy. They're down the hallways too. So we do like to include those departments as well, and they've been helpful. During the weekly meeting, we review the falls that have occurred, the interventions that have been put into place, and discuss any other interventions that might be appropriate, and that's individualized to each resident. We also discuss any residents that are at high risk for falls, such as new admissions, residents that have had a decline in health status that just aren't doing so well. We just also discuss any falls or safety concerns daily, Monday through Friday, at our safety huddles, in which the department managers go to every lane and meet with the floor staff to discuss any safety concerns with falls and, any other general safety concerns in the building. We have included our consulting pharmacist. We also had him review resident medications that have either been falling or high risk for falls, and to determine if there was any medications that may have been attributing to that as well. So just a lot of different avenues from us that we've been trying to reduce our falls, and then so far, so good.
Yeah, excellent. For sharing that information. I had just jotted down a note here when you said who the team was consisted of, and I said, oh, add the PharmD, and then you did that at the end there. So,
well, I wanted you on the edge of your seat, Dr. Jurevich.
Thank you. I'm typically on the edge of my seat, so I may fall off. But did you have any thoughts about whether the PharmD recommendations were actually followed through by the providers?
Yeah, because Rick will put it into, because we do point click care, and he'll put it in, and generally they do. The physicians here respond very well to the pharmacists. I mean, even from an infection control standpoint, when I'm telling them like, hey, you're a little too wild with that one, usually they'll tone down. So
yeah, good. Yeah, because it's interesting. Wanda Cavitz on our collaboration here, and boy, it's been a couple of years now since I made a visit to the veterans home. But this issue came up about multiple medications that were causing falls, and so that was a point of discussion. We said, well, this patient really should, have trimmed the sails. I mean, he's on 2 antipsychotics and he's on 3 antidepressants. So some of these medicines have to go. So I actually had a conversation with the patient, and he was just real reluctant to get rid of any of the medications because his psychiatrist said, don't let anybody touch these medicines. You need to be on these. And so, it's always this argument between the geriatrician or the primary care doctor and the specialist, as to what you're trying to solve. And so I'll give you an example of what happened with our cardiologist one time. They had a heart failure patient, and they kept pushing these hypotensive medications to open up the heart more. And the poor person, the poor patient had 80 to 90 systolic blood pressure, and they said, oh, they were perfusing so much better with that. And I go, yeah, but they're falling like crazy because they're orthostatic blood pressure check or orthostasis. So what are you accomplishing? So if you get somebody that's got better perfusion and then still falls and breaks a hip and dies, I mean, then what have you accomplished? So there's always a battle, quite honestly, between specialists and primary care. A lot of this primary care know, what's linked to these medications, but sometimes the pressure from the patient. I mean, yesterday isn't a good example. I had a patient who just was just going at me like there was no tomorrow. You took me off this medication. I said, yeah, because you're falling 10 times a week. The medication's making you fall. Well, it helped me. I said, how does falling help you, right? So there's tremendous lack of insight a lot of times about the relationship with the medications and the lack of understanding that they're associated with falls. So it's a battle. And the other thing I was going to ask Jean, Michelle, and Kelly is, how do you approach the outlier, that we were talking about here? This person is falling 10, because that can't always represent the fall, the signature or the value of the nursing home. Admittedly, we have to count all falls, but if you're looking at a systems change, if you have an outlier, you can't make any judgments about what the average fall is. So the average is 2.6 falls per resident per year. And now you've got somebody who's got 10 times that number of falls. That does not reflect, the overall. So I just wanted to get our quality improvement experts here to just think how they would approach that.
First and foremost, I would just say it's great that you guys took everything off the table that you had in place for that person and reevaluated, because I think more times than not, we add on one thing and we keep adding it on and then they're not really helpful. So I think going back to the drawing board was the best step that you guys took. Now, as far as looking at it from your quality measures standpoint, you're always going to have that, amount of falls because this person is an outlier. But as long as you're doing what you need to make the best possible situation for that person, you can, I don't want to say argue your point, but you can justify why that triggered for you.
Well, and even if like state surveyors come, they can see that we have done interventions. We've formed committees for this resident, and it does help protect both the resident and the facility. And also one other thing is we had also involved our activities department very heavily as well, going back to what type of a person she was. She did a lot of traveling, did some things as far as going on a safari on the video and things like that. So, yeah. I mean, it's been a lot of different departments helping with that. So,
yeah, and I think that the value of bringing back into the picture a CNA who has had a long-term relationship with her is also so that they understand some of the changes that have taken place and the history around this individual.
Yeah, and you can put 12 interventions on a care plan, but if none of them are working, it's irrelevant. It's the quality of intervention, not the quantity. And I think that gets missed sometimes. So I just go back to great job cleaning the care plan and starting fresh.
So Jean or Michelle, do you have any thoughts about how to interpret data that includes an outlier like this? Would it be a fair way to assess your overall system program by pulling out that data point from that frequent faller and then looking at what the more average facility is resident is doing?
Actually, as far as the CASPER reports go, that is already accommodating that. How your fall looks back 180 days or whatever, 275 days. You're looking, was there falls? And they're marking that. They're not capturing that multiple frequent fallers isn't really captured in the CASPER. So you do get that compensation there. And then when you're doing your individualized tracking of each individual fall, that's where you see those outliers pop up. So if you have those two mechanisms, I think that definitely helps you with your focus work and then also with what the surveyors and the public is seeing about your work on Care Compare.
Yeah, thank you. Yeah, for that point. And it's well, we did a fall study at Villa Maria last year, and we found that there's really a fairly even distribution of fall frequencies, which was fascinating. And I don't know if anybody's ever reported this, but there were like groups that had 0 to 5 falls. Well, actually, no 0. It was 1 to 5 falls. Everybody fell. So there was no fallers, no non-fallers. So we had 0 to 5, and then we had 5 to 10, 10 to 15, 15 to 20, and 20 plus. And so, the numbers went down in terms of, so there was, fewer and fewer people that had that fall frequency. But what was kind of fascinating is that what we were looking at was the variation in their blood pressure. So people that had big swings between their blood pressure from month to month. So we did 10 months worth of blood pressure checks and once a month blood pressure checks, and use those numbers. And the people that were falling more than 10 times during the year had the highest variability in blood pressure. So we're trying to put 2 and 2 together here. Where when you have high blood pressure variability, it usually means that you have very non-compliant blood vessels, and so that's kind of suggesting that maybe these people are also pretty inflexible. They might have a lot of stiffness. So the question is, a little deeper dive into that and to try and find out if this is in fact true. in terms of their flexibility, and maybe just their lack of flexibility prevents them from compensating when they have a postural, what we call a postural perturbation. So, it's maybe a little bit too researchy if you don't have to come to any conclusions, but again, looking at every, different factor for the multiple risk factor. And just as a reminder, people that have diabetes have peripheral neuropathy, so they can't feel their feet so much. And so, there's some research where they're putting an insole with little nubs around the outer part of the sole of the insert, just to give people a little bit more of a pressure contact to know how they're placing their foot. So anyways, and just to add a few more thoughts, podiatrists, sometimes the podiatrist can help figure out if there's, half of people with foot pain have falls. So foot pain is a under-detected source of falls. Other sources, well, we'll talk about this, but I'm going to really go off on a rant here about fall prevention and all the different factors. So I don't want to get ahead of myself, but that's really phenomenal. I really appreciate Ave Maria sharing their information with us. And at some point, what we'd like to do is get the graphics, to show where your change, put a little down arrow that shows where you've done your PDSA cycle, and then to reflect the following month's data as to whether the fall rate went up or down. So those would really be useful visuals. Any other thoughts, Michelle or Jean?
No, I see in chat that Amanda Gilbert is wondering if the list of interventions for restlessness can be shared.
Yeah, I don't know. Kelly, do you have any quick thoughts about that? I was going to mention something.
I think she was just wondering about something that Andrea from Ave Maria mentioned. So, but I think we do have some lists of.
Oh, do you mean like the list for like the activities that we did, or the list of everything we tried to prevent falls?
Just
Interventions for
the restlessness, I guess, the activity.
like activities.
Yes.
I mean,
Like
they're-
different activities.
we can, they're
Yeah.
patient-centered.
Yeah, we can send, what we have, Jean, and see if anyone else hasn't thought of some of what we have.
Yeah,
I like
yeah.
to
Well, that's perfect. That's
her.
go ahead.
So that you were trying to figure out her, and you knew that she liked to take trips and such. So you did these virtual trips, and that really shows that you're doing person-centered intervention. And that's really what makes the biggest difference. If it's something that they enjoy.
Yeah, exactly.
We
So-
also had a one-on-one volunteer come in as well when, she was kind of at her peak with the falls, and that helped as well.
Yeah, good to know. Yeah, so the one-on-one is always fascinating, because in the hospital, that's always my go-to arrangement for delirium, is to have one-on-one. And of course, hospital policies are always crazy. Sometimes they'll allow it. Sometimes they will allow a family member. Sometimes they ran out of money because they don't have money for sitters anymore. So it's just all over the map. Yeah, that concentrated effort and one-on-one is so important. But also equally importantly is just for Amanda's point here, is that as we look at each of our PIPs, for fall PIP, what have we done and what has worked and what hasn't worked? That's the kind of information that we want to disseminate and share. And that's the advantage of being part of this group, is that, we learn from each other's experiences, in addition, hopefully, to what we call evidence-based medicine. So when I mentioned previously that having people walk with distance glasses and not bifocals or trifocals is a way to reduce falls, that's evidence-based medicine. So we want to share, what we know in the field in the science of fall prevention that works. And, these are all very incremental, right? They're like, reduces falls by, 1 to 5%, but, they start adding up. So just, even as a PIP or a Plan, Do, Study, Act cycle is to get families to convert to just distance eyewear if necessary, and to get rid of the bifocals and see if that changes the needle on falls, would be an evidence-based example, for a Plan, Do, Study, Act cycle. The other thing I'm going to mention, just because we're kind of getting short here on time, and I'm not going to be able to get into my fall presentation, which is absolutely great because I much prefer the conversation than my slide decks. But one of the other things to think about is what's called dual task therapy. And that's another intervention where you walk individuals, and it's kind of one-on-one, particularly with the demented patients. So if they're cognitively impaired, you walk with them, and then you have them look at visual, spatial things, like on the wall. You might have circles. What do you see up there? And they name it. It's a circle, or what color is that? It's a blue circle, or something to that effect. That kind of cognitive engagement forces the walking to rely upon the spinal cord balance mechanism than on the cortical. So it's called dual task therapy. And if you really can, even more importantly, rather than the visual spatial part, have them count backwards while they're walking and do that as a session. That also is called dual task therapy. So that, again, is another idea, evidence-based, that you can implement in one of the months for fall prevention, and say, we're going to try dual task therapy on the Alzheimer's unit and see if it makes a difference. A third idea would be to empirically treat pain. So people that have wandering or restlessness or increased agitation, empiric treatment of Tylenol, 1 gram twice a day, is another type of intervention that you might want to look at as a fall prevention intervention. So those are at least three ideas that you may have heard about or may not have, and if not, it may be something worth looking into as a Plan, Do, Study, Act cycle.